Shall I start?
Yeah, please.
Good morning, everyone, and very warm welcome. I'm here to present my topic, comparative study between dacryocysto-rhinostomy with bicanalicular intubation and dacryocysto-rhinostomy using mitomycin C, no financial interest. So dacryocysto-rhinostomy is surgical procedure to create drainage between lacrimal sac and nasal cavity via osteum, and external DCI is considered gold standard with success rate of 90%, while 10% cases still fail. So the aim of present study is to prospectively and comparatively explore the efficacy of bicanalicular intubation in DCR over DCR using mitomycin C in preventing recurrence and also compare the surgical outcome. This was prospective study done for 2 years in 28 patients presenting to OPD with symptoms of NLD obstruction and chronic dacryocystitis. Of 28, 22 females and 6 males that were randomly divided into groups of 14 each, and in group 1 of 14 patients, DCR was done with bicanalicular silicone tube intubation, and in group 2, DCR was done using intraoperative mitomycin C. We included the 20 to 60-year age group, NLD obstruction and chronic dacryocystitis, and cases with acute dacryocystitis, nasal pathology, canalicular obstruction or previous drug surgery were excluded, and preoperative evaluation for local ocular or the ENT evaluation done. Curvilinear skin incision of 10 to 12 mm was given along the anterior lacrimal crest, and we created 12 mm into 12 mm osteotomy site. In group 1, bicanalicular silicone tube intubation done through upper and lower puncta, and drainage tube was tied to 5 external layers by 5-ethanol. And in group 2, 0.2 milligram per ml mitomycin C soaked cotton sponge were applied over the osteotomy site under the surface of lacrimal mucosal flap 1 by 1 for 4 minutes. We did nasal packing, removed after 24 hours, and patient were followed at first week, first month, third and sixth month. And intubation tube was removed at 4 week, and patency of NLD were confirmed by syringing. We used the SSP software and chi-square test. So the patient undergoing canalicular intubation DCR, in results, DCR with bicanalicular intubation, 13 out of 14, that is 92.9% patients showed the successful DCR with reference to relief from EP4 and successful syringing at the end of 6 months. And in group 2, DCR with mitomycin C, 85% patient, that is 12 out of 14, showed the success and 2 cases failed. However, the p-value is not significant. Maximum incidence was found in 31 to 40-year age group, and 78% were female. There was female preponderance in both the group due to narrow lumen of lacrimal bone, canaliculi, NLD, hormonal, and also the osteoporotic changes. And success rate is more in bicanalicular intubation. And the success assessment criteria is EP4 and successful syringing at end of 6 months. And the commonest cause of DCR failure that we encounter are obstruction at common canalicular osteotomy site closure that is well solved by the silicone tube that prevents the blockage and allows the epithelial tract to form around the tube. And on mitomycin C, antiproliferative agent prevents scarring. So our study has a limitation of being small in sample size, and also the duration of follow-up is short. Thus, our study suggests that by DCR with bicanalicular silicone tube intubation yield more success rate than the DCR with mitomycin C, though mitomycin C is also the effective results, and bicanalicular intubation can provide the additive beneficial effect in canalicular obstruction, punctal problem, osteotomy site closure, and preventing the recurrence. Thus, DCR with bicanalicular intubation can be good choice of surgery for the NLGO cases. These are my references, and thank you so much.
Or in each and every cases, intubation or either intubation or MMC?
Sir, in our cases, we found that the DCR with intubation is having the more success rate than of the mitomycin C. We randomly selected the primary cases of NLD obstruction and chronic dacryocystitis, and we divided into group. And for one group, we went for the DCR with intubation, and second, mitomycin C DCR was done.
That's you already informed.
Yeah.
I want to know: are you advocate for each and every cases either for silastic intubation or MMC?
Sir, this is something quite debatable, having varying view. Some surgeon prefer that in the failure cases or the repeat cases, DCR is more successful with the intubation. But a few of the studies, also the study by Dr. Javed Ali sir, and there is one study of the 20-year retrospective study in the patients, which suggests that also the primary cases, or in maximum number of cases, DCR with intubation, if selected, good case selection is done, is a very good choice of surgery.
Okay, as it is a competitive session, I want to ask another question that tell a few complication of silastic intubation.
Yes, there are the complications of celastic intubation. One is also the granulation tissue formation, maybe the loss of the tubes, or maybe the laceration of the canals. However, to prevent the loss of the tube or incorporation of the patient, we selected the 20 to 60-year age group to have the cooperation of patient and excluded extreme age of patients.
Okay, thank you.
So we removed the intubation tube at 4 weeks. Beyond the 4 week, there is biofilm formation has been reported in the various studies. So it will itself go into various complication if we prolong the timing. So 4 week was our removal of intubation.
How much percentage of mitomycin was used and for how
हाँ,
long?
yeah, ma'am, 0.2 milligram per ml mitomycin C was used, and it was used for 4 minutes. Various concentrations of mitomycin has been tried, and we found that the 0.2 milligram per ml concentration, for which we keep it at the 4 minute at the various sites to
So
prevent
for
the
all
scarring and
patients, it
fibrosis.
was maintained.
Yeah, yeah.
What type of randomization did you do?
Yeah, ma'am.
What type of randomization did you do?
I didn't get it, ma'am.
What type of randomization did you do to split it into 2 groups?
So, ma'am, it was a double randomization. We did not had the matlab, which of the patients are going in which criteria, and
So what's that name?
double randomizations.
Double. Okay.
Thank you, ma'am. Thank you, sir. Thank you, everyone.
Ravi
Who is the
Ranjan,
next
Dr.
speaker who is present?
Ravi Ranjan, please. Dr. Ravi Ranjan, please.
Very good morning, everyone. Topic for today is efficacy of probing and syringing as a treatment for nasolacrimal duct obstruction in adult. That is, this is the story of a small steps. I have no financial relationship to declare. Majority of the nasolacrimal duct NLDO found in adults is idiopathic or primary and is caused by partial stenosis or complete obliteration of the duct lumen resulting from idiopathic inflammation and fibrosis of nasolacrimal duct, and that it is a syndrome of unknown etiology. And it is postulated that inflammation of unknown etiology results in possible occlusive fibrosis of the nasolacrimal system, causing obstruction and subsequent epiphora or watering eyes. And it is tough for anybody working in periphery like me to convince an epiphora patient to go for operation or his first arrival in OPD. Considering it, I started SAC was first for their satisfaction with topical moxifloxacin eye drop thrice daily for 7 days, and after that I convinced them for DCR if no improvement. And surprisingly, many of the patients recovered well of their epiphora. Then I planned for this study, and it is a prospective interventional observational study that was conducted on 263 patients with epiphora from July 2011 to July 2022 who had epiphora for 3 to 24 months, and 263 patients were divided into two groups randomly, and a group A consisting of 130 patients. They were probed and syringing with moxifloxacin 0.5%, and group B with mitomycin C 0.04% done through a lower canaliculus. And patients were excluded if they had epiphora present from birth, congenital abnormality of annulus, watering secondary to herpetic canaliculitis, dacryocystitis, lacrimal sac mucocele, patient with previous trauma, patient with abnormal punctal apposition, and probing was carried out with a smart probe usually size 3 to 4, and through the lower canalicula's. Just as a simple syringing and probing, and a gentle force is used to break any fibrosis band adhesion membranous at any point in the nasolacrimal duct, including its lower end, and the whole procedure is repeated three times from the lower punctum. And patient was treated with topical moxifloxacin 0.5 milligram eye drop thrice daily for 7 days and oral analgesic if pain. And the patient were followed up on day one after 1 week, 6 weeks, and 3 months, 6 months, 1 year. On each follow-up, history and watering of and patency of nasolacrimal duct was determined by syringing. And at the end of the mean follow-up period, that is 1 year, in a group A, 26%, that is 20%, and 33 patients from group B were completely relieved from symptoms and patent on syringing. That's a probing in adult is quick, safe, and easily performed with local anesthesia, cost effective, and it is potentially an outpatient procedure. Few studies have reported an efficacy of probing for the treatment of chronic dacryocytosis with nasolacrimal duct obstruction. Lacrimal irrigation occasionally may be therapeutic by dislodging and obstructing a stone or concretion or widening a partially stenotic passage. And in some cases, adult patients are completely relieved of the symptoms after nasolacrimal probing and irrigation. Others are only relieved temporarily or not at all. That in conclusion, in our study, no significant difference in efficacy of syringing material, whether it is moxifloxacin 0.5% or mitomycin C, and it is simple, quick, cost-effective day case procedure, doesn't compromise the patient for further nasolacrimal surgery. A single probing procedure is effective in producing symptomatic improvement when limited to use in patient with complete obstruction of the nasolacrimal duct and when watering was the only symptoms. And in our study confirms that probing as an initial procedure is an adequate and minimally invasive treatment for adults and can be alternative to DCR, especially in elderly patients in few cases. Thank you.
So it's a good, okay, your observation first, but it is most of the time is a controversial probing in adult population because that it depends on the etiology. If it is that NLDO is already scarred, in such cases, what is your hypothesis to overcome it?
Sir, I have done syringing and probing, and whatever I have got, I am presenting here.
No, is there any other, most of the time is bendo, there is a scar formation on the NL2 itself. So that's a point, those people are advocate
Actually,
for
I have done maximum for 3 times.
3 times.
Yes. And after that, if there is
It's
no
okay.
improvement,
Your treatment, what are the methodology, everything, there's no such questions. And that question is on the basic pathology. There is a scar formation on the NLDO itself. What are your hypothesis or your other authors' hypothesis? What are the method to overcome that is scarred NLDO? Because in case of a congenital is well known, it is due to the fulvar vascular or somehow it's overcome because it was not imperforate, so it's perforate. But
that's why success rate is only 20%, sir. That I have to.
Okay.
So if there is no success, I go for DCR.
Okay. Yes, please.
Sorry. These were all frankly Roplas positive cases, or were they diagnosed?
It is going. I'm not
Sorry,
getting.
but they were all frankly Roplas positive cases. They were successful with probing.
Yeah.
Okay, and how much was the follow-up?
Actually, I am not getting your question.
The follow-up, sir. The maximum follow-up period.
Yeah. On 5th day, after 1 month, 6 months, 1 year. If they are doing well, then
So
I
up to 1
continue.
year, all of them were successful.
If they are doing well, I continue follow up. Otherwise, in the meantime, I go for DCR. If there is no benefit at all, I go for DCR.
Okay. I also was agreeing with Sir, like there was fibrosis of the NLD. The pathophysiology of the Pando is that. So, how a probing would be successful is a question, but it's interesting. Thank you.
Sir, what was the mean age of this study?
Patients range from 7 years to 74 years.
Okay.
Actually, I haven't calculated mean age. That was not a part of my study. My study was syringing and probing.
Okay, sir.
Thank you.
Parvez, please. Dr. Professor Siddiq Parvez Ahmed. Next one is Dr. Sibani Barma. Okay, sir.
Good morning to the honorable chairpersons on the dais. This study to evaluate the patient of chronic dacryocystitis was done in commission with the radiology department of our medical college to rule out the site of blockage, because dacryocystitis patient have got a dilemma where the level of block is there. Even with the many investigation which you carry out in a conventional day-to-day activity, we cannot find out the site of blockage. And one of the most important complaint with these patients who had attended our OPD had epiphora. And chronic dacryocystitis is one of the most common pathology involving the lacrimal drainage system. These are the few of the representation of the patient suffering from chronic dacryocystitis. Exclusion criteria was acute dacryocystitis, because we do not perform these types of tests over there. What is the rationale for performing a dacryocystogram? Because it assesses the functional anatomy of the lacrimal drainage system. It determines the site of blockage and stenosis. It provides us an appropriate detail evaluating the indication of surgery, and also help us to decide the type of surgery which could be indicated in these personnel. Aims and objective are very clear-cut from the very basis, to assess the site of obstruction and to diagnose lacrimal system pathologies like diverticula, fistula, tumors, etc. This is a prospective observational study carried out last year. The inclusion criteria, primary ocular examination, and everything was done according to the ethical committee study which was proposed by our college. After a complete workup and a verbal consent, the Iodoxol, which is a water-soluble and non-toxic, non-ionic contrast provided by the radiology department, was done. Technique, we are all aware of the technique. A Cardwell view was the optimal imaging modality for the adequate visualization of the lacrimal system. I'll show you how it was done. And this was, the film was taken by the radiology resident and the consultant. This is the procedure which is being performed. This is an 18-year-old adolescent girl having complaint of watering. Right eye syringing showed lower complete block with regurgitation of mucopurulent fluid. Dacrocystography to locate the level of blockage. You can see in the contrast enhanced radio opaque films the level of blockage over there. A result, out of the 50 patients, we could advocate only 50 patients because the workload was not so much. Out of the 50 patients, 37 patients were female, which indicate a female preponderance, not documented in much of the studies, but we had this particular ratio. And as far as laterality was concerned, it showed a left laterality, but nothing has been documented to date as far as laterality and of the study is concerned. This is the depiction of the block. The yellow one and the blue one denotes NLD block, and the red one denotes common canalicular and the canalicular block. Maximum cases had block at the level of nasolacrimal duct, and canalicular block was present at the level of 5% in our study. Maximum cases had distended sac followed by normal sac, though the patient had a normal sac. And the bottom line and the thing which we wanted to find out were the fibrosed irregular sac, in which the treatment modality changes dramatically. So we were in a view to find out this particular fibrosed irregular sac also. The surgery, the question was that we'll go for the discussion. 50% of the patient of chronic rachiocystitis were studied between 12 to 70 years of age. Most patients presented with complaint of intermittent conjunctival hyperemia and epiphora. All patients were subjected to careful slit-lamp examination. And dacrocystography was performed using Iexol as radiopaque contrast, which is water-soluble ionic medium. I think the time is finished, no?
Yes.
The time is finished, sir? Okay. So this for the discussion part on my paper.
You can go ahead.
I can go ahead.
Yes. Sum up within 1 minute, please. Try to finish within 1 minute.
Okay, okay.
Please
fine.
continue and finish
Thank you,
within 1 minute, please. Yeah.
We had come up to the discussion. Demographic profile of these patients. We have females attributed to narrow lumen of the lacrimal passage among the female. This is documented to a certain extent, but we had this particular ratio of 3.4:1. Laterality, I have told you, nothing is presented in the literature as far as the laterality is concerned. The third topic of discussion was level of block. In this study, the most common site of block being the necrolacrimal duct obstruction, followed by canalicular block. The lumen of NLD being slightly tortuous and irregular leads to stasis of secretion, and as a consequence, stenosis sometimes develop. Agarwal, it's a very long back study. 72 was able to conclude that the major obstruction site was a junction of lacrimal sac with nasolacrimal duct, followed by nasolacrimal duct proper obstruction. The type of block, according to the study, complete block around 75% was found in the majority of the patient, versus incomplete or partial block could be noted in 25%, means the dye was present inside the sac and no movement of the dye due to gravity was observed in 75% of the patient. As far as sac morphology is concerned, in the study on observing the morphology of the sac, 30% showed nearly normal sac. As far as the dimension of the sacs was concerned, 20% showed small, irregular, fibrous sac, and 40% shows 42% had a distended sac. This is similar to the finding in the study. Enlarged sac was found to be higher in proportion than normal sac. Study by Malik also showed distended sac in majority of the patients with chronic dacryocystitis. Other significant finding in the study, 2 patients had external fistula. None had internal fistula communicating with the nasal bone. Residual sac was noticed in some patients following DCT. There were no cases of filling defect, diverticuli, lacrimal stone, and bone fracture in my study observation. Conclusion, the dacryocystogram is easy to perform and provide good imaging quality. With less exposure to radiation, we have got 128 helical scan, CT scan also. We have got MRI also, but the basic was that this conventional dacrocystography is one of the modality in which you can delineate the common canaliculi and the canaliculi. Whereas the dye used at the Pector technique scan and other contrast medium used for CT scan, we are not able to delineate the common canaliculi and the upper and lower canaliculi. It was evident from the finding derived from the study that dacryocystogram is a safe investigation modality in hands of skilled ophthalmologists, and it is the gold standard modality for imaging lacrimal drainage system. It is to localize the level of block and evaluate conclusion that DCG enabled us to meticulously plan the treatment for chronic rachiocystitis and provide better surgical outcomes.
Okay. Just please tell me few of that problems with this system, this dactylocystography.
I didn't get
You may face there is some drawbacks
Yeah, yeah.
of dactylocystography. Can you please summarize few points?
Are you talking about the level of blockage? Or are you talking about the types of blockage which I encountered?
No, it is blockage, but most of the time it is not required in our day-to-day practice. So, in which cases you will prefer
Acha, in
dactylocystography?
which cases I have preferred? Sir, the
One,
question,
second one is what are the drawbacks of this procedure?
Sir, we had taken around 50 cases who had a history of epiphora. And they were persistently having a conjunctival hyperemia. It was just a study to diagnose, it was just a study to delineate and diagnose the level of blockage. It's a prospective study which we wanted to for observational purpose. And the patient had the history of epiphora, congenital hyperemia. And we have taken these patients just to have a bird eye view of where is the level of blockage in the patient suffering from chronic dactylocystis. We just wanted to know what was the level of blockage. That was our aim of the study.
Yes, yes. But there is some other alternate like that we can go for a diagnostic probing, one of the very simple technique, diagnostic probing. So,
I agree with you because we had done these types of techniques also. We are routinely doing it. We have a paramedical course running in institute. We have
Yes.
we have got 10
As
PGs. We are doing it.
that's
But it was
why-
just it was a measure to find out the level of blockage from our side. It was just our endeavor to find out what is the site of blockage, whether and what are the status of the sac in patients suffering from dactylocystis. We were just wanted to find out, and what is the main rationale was to see the status of the sac. In how many patients you have a fibrous sac, in how many patients you have an atrophic sac, how many patients you require a physiological recommendation for MRI and all those. So it was just an opportunity for us to see the status of the sac. That was the main. Level of black was delineated, and even the status of the sac was also delineated from our side.
okay.
Thank you.
Sir, once again, sir. Sir, you mentioned your.
Okay.
Sir, just one question.
In what way?
Sir, you mentioned your management will differ if the sac was found to be fibrosed or distended.
Definitely, Dr. Saab, how will you perform a DCR in a fibrous sac, which is a non-functional sac? You are all aware of it. We do not perform in a fibrotic sac. I've shown you my data on the fibrotic sac. I don't think it is rational to perform because the flaps will not be able to suture the flap. In spite of using other modalities of mitomycin and all those, but the sac itself is quite fibrotic. I don't think it's rational to perform conventional. We have referred these cases to a ENT department for endonasal DCR. There they have found a better result as compared to the conventional DCR. Our professor of ENT department, she is doing some research. These cases were referred to the ENT department, where they had endeavored to clear it out. They had the resident standing beside that also. But I prefer, it would better if we go for with the cooperation of ENT department also.
How do you find fibrosis with dactylocystogram, sir? How do you find the fibrosis? How do you diagnose? How do you detect
Madam, I have got the
fibrosis?
pictures of the fibrotic sac in my study. The sac of the normal sac, you can see, I can show you how it looks like. A distended normal sac, how it looks like, I'll show you that. You can see a distended sac over here where you can see a sac over here. If you look into the diagram on the left side, you can see a sac which has been performed and you see a right on the left side of you, the right side. If the picture gets reversed, on the left side you can see. And the fibrotic sac, the dimension were very shrunken now, fibrosed, as compared to the normal sac.
So thank you. Our next speaker is Shibani Barma. Dr. Shibani. Okay, I think absent. Then next speaker is that Vishwanath Sahu. Dr. Vishwanath Sahu. Then we can jump to our next, Dr. Shurobhi Priyadarshini. Again, I think absent, everyone. So, Raz Badar. Okay, then Raz Badar also absent. No? Then next is our Dr. Rupali Barnawal. Dr. Rupali Barnawal. Again absent. Next, Dr. Bijaya Labana. Dr. Bijaya Labana. Almost at the end now. Dr. Rai Arpita.
Good morning, respected faculty and everyone present here. I'm presenting my topic, the correlating the blink rate and screen time in computer vision syndrome patients in our tertiary care hospital. Computer vision syndrome is defined as complex eye discomfort and vision problems associated with prolonged exposure to digital screens. This definition is according to the American Academy of Optometrists. This has undoubtedly become the most common occupational hazard of the 21st century. The symptoms and complaints comprises of eye strain, giddiness, redness, watering, blurred vision, headache, and asthenopia. A review by Blem et al. Suggested that dry eye during screen usage could be caused by either due to decreased blink rate or increased corneal exposure produced by primary gaze position of the screen. Other contributing factors leading to dry eye in computer vision syndrome include poor environmental conditions caused by poor air conditioning or poor humidification of the room. Blink rate decreases as font size and contrast are reduced or if the cognitive demand of the task increases. An additional factor to consider is the completeness of the blink rates, that is whether the upper lid completely covers the exposed cornea during blinking process or not, as incomplete blinks have been found to be associated with inferior corneal epithelium damage and inferior pre-blink tear breakup. The normal blink rates, as we know, are 12 to 15 times per minute. Working on distal screen can reduce the blink rates to up to 5 to 7 times per minute because of the continuous staring and high cognitive demand needed while working on distal screens. To determine whether it is the computer screen viewing that produces the change in blink rate, the present study compared the blink patterns when reading either from a desktop computer monitor or a hard copy printed text under equivalent viewing conditions. The aim of the study was to evaluate the spontaneous eye blink rate in a patient of computer vision syndrome and to correlate the blink rate patterns with their screen time and their ocular symptoms. We included patients of more than 10 years and up to 60 years whose screen time was approximately greater than 2 hours per day. We excluded the patient of keratoconus, amblyopia, corneal scarring, facial palsy, lid disorders, meibomian gland disorders, who had any previous use of any topical medications other than tear supplements, who had any use of systemic medications like diuretics, beta blockers, OCPs, as these cause dry eye, any previous history of ocular trauma, chemical injuries, refractive surgery, and contact lens users, any previously diagnosed patient of dry eye, Stevens-Johnson, ocular cicatricial pemphigoid trachoma, and Rayleigh syndrome patients. This was a cross-sectional study carried out at the Regional Institute of Ophthalmology. It was of 50 patients were selected, 25 males and 25 females, aged between 18 to 60, randomly selected with screen time greater than 2 hours per day. Firstly, these patients were asked to perform a continuous 20-minute cognitive demanding reading tasks from a desktop computer screen. Post 10 minutes break, they were asked to read the same material from a printed hard copy page at a viewing distance of 50 centimeter. Identical text was used in 2 sessions, which were matched for size and contrast. Target viewing angle and luminance were similar for the 2 conditions. Their blink rate and blink rate patterns were video recorded during the task, but it was not disclosed to the patients to calculate the SCBR percentage of complete blinks and incomplete blinks. After they are done with their task, subjects were asked to complete a questionnaire regarding the ocular symptoms experienced during the trial. The socio-demographic variables like age and gender, the type of electronic devices used, SCBR per minute, percentage of complete and incomplete blinks, the time spent on them per day on an average were taken as exposure variables, and ocular symptom experience were taken as the outcome variables. A descriptive analysis of all the explanatory and outcome parameters was done, and it was recorded. SPSS software were used for statistical analysis. In our results, we found that in terms of time spent on the digital devices per day, 12% of the patients spent approx less than 2 hours per day, 53% of the patients used screen for approximately 3 to 6 hours per day, and 35% used it for greater than 6 hours per day. This was comparison which showed that as the screen time increases, the blink rate comparatively would reduce when compared to the screen mode and the hard copy mode. And this shows that as the screen time increases, the patient has comparatively more ocular symptom experienced. So this study confirms that the decreased the blink rate and increased percentage of incomplete blink are responsible for the ocular symptoms. And also confirms that patient who used digital screen greater than 6 hours per day had comparatively decreased blinking rate as compared to the ones who used screen for less than 6 hours per day. And this proves that smaller digital devices such as mobile phones, especially held at distance of 20 to 30 centimeter from the eyes, are proving to be more responsible for causing the digital eye screen. And it's advised to use special tints and coatings for screen to avoid the digital eye screen. Thank you.
Good study, of course, is a very relevant study due to our today's era, today's practice. So, to avoid computer vision syndrome, what will be your take-home message to your patient?
So first take-home message is to avoid usage as far as it is in our hands. If it's necessary, then it's not in our, it's mandatory we should use, but if it's avoidable, then we should avoid like viewing screen as much as possible. The basic precautionary method. Next is for following 20-20-20 minute rule, that when we use screen for approx 20 minutes, we should take a 20-second break, and we should view something at a 20 feet distance. We should view the object so that the muscle relaxes. The main asthenopia symptom, which is responsible for the computer vision syndrome, that can be cured by the 20-20-20 minute rule. And the screen coatings and tints and the blue filter glasses, although they have studies have been going on, but they are more like of placebo. What I felt that the patients say that they are feeling relaxed after using this blue filter screen, but they are more kind of placebo according to the American Academy of the studies done according to them. But they have proved, at least as a placebo, they have proved to be effective to follow the blue filter glasses. Next, the viewing angle and the distance at which we use the digital devices. This is very important. The environmental, like if we are using very airy places where the wind velocity is very high, so the evaporation rate of tears will be very high. So that can cause to more eye strain, and we should avoid using screens in the night time. The room should be properly lit. So these factors can like help reducing the symptoms for the computer vision syndrome.
Yes. Okay, fine. I think that we can now 5 minutes more, but if you have any question to the any, then we can discuss, we can utilize 5 minutes, otherwise we can conclude it now. Madam, if you want to say something, we can, okay. Yeah. You say.
Other speakers are not there, I think.
Yes, yes. Okay, okay, please. Please.
No.
Yes, sir, we can hear. It's
Yes.
on.
Yes.
Good morning. One comment and one question allowed.
Yes, yes, please.
Before any SAC operations, I would like to suggest one thing, that at least we should take ENT opinion first. This is my comment. And one question is that regarding that our the doctor, that is smart probe was there. What was that smart probe? But the paper presenter is not here.
Yeah, exactly. That a smart probe is some one company developed. It is with that marking, with a marking, This is actually they claim it as a smart probe. The same type of probe, that is, it has some marking in mm. So you can assess how many millimeters is already inside. So at that what level there is a block. Basically, that smart probe was developed to rule out any canalicular obstruction initial phase. So suppose obstruction at 9 a.m. or 8 a.m. 6 mm. Accordingly, that with the smart probe you can assess. In the normal probe, if you want to do a diagnostic probing, my technique is that, so I just hold with at the end. Once there is soft stop or whatever, I just with a one plain good forceps, then I measure with a simple plastic ruler or any other ruler. Maybe a wooden, maybe plastic, whatever material available, good quality. That's enough. But with the smart probe, if you don't have done any forceps in your hand or scale, so you can assess. It is a 9 mm like that. And for probing also, it can guide you. That's one.
Right.
Regarding your first one, that ENT opinion, some of our ophthalmic surgeons also doing lots of endoscopic DCR.
Yes.
So that's the reason. That's myself as I will be feel I will be more confident if I examine myself my cases endoscope. Your endoscope is there. There's a no need. As per Ayushman Bharat is concerned, they want one X-ray. For that one X-ray. So X-ray also one of the indirect evidence. So you can order for X-ray and you can go for a endoscopic evaluation if you have. But unfortunately, most of our ENT surgeons, they do not have that endoscope. If you are referring the patient, if you have an endoscope, but you don't have that, your ENT colleague don't have any endoscope, then it will not be a justice to sending him to the patient for evaluation. Rather, for safer side, if you want to go for a safety point of view, then you can go for a X-ray PNS.
Yes.
Which can exclude DNS and maxillary synovitis or whatever any other pathology. So from a legal point of view, you are almost okay, and then you can go for endoscopic evaluation.
Yes. Thank you, sir.
I always prefer my cases. I will evaluate myself.
Thank you, sir.
Yes.
And one more question regarding this computer vision syndrome, whether this ARC, anti-reflective coating, these blue ray lenses, are they really effective?
Companies are claiming,
Yeah.
but on the reality, there is no such proof. But companies are, that is a business market. Basically, is a marketing trend. They are claiming so many things, but there, on practical, there is nothing. So that's why I'm asking very valid questions. So in computer vision syndrome, blink as much as possible. Then whatever, sir, next is that is suppose you are in a AC room. Once you can go out, then you can just acclimatize your climate with your outside. Those are the very important tips. So education is one of the big role on that patient's education. That's okay, sir. Thank you, sir, for your question and your comment. Yes, I think we can close it. Thank you, everyone. Thank you.